So very good afternoon, everybody. Thanks, organizer, for giving me this opportunity. So my topic of discussion: post-Osimertinib options in mutated EGFR lung cancer. As Dr. Tanmay is already mentioned, that mechanism of resistance of osimertinib, third generations TKI, the most common targetable mutations. Osimertinib emerges standard of care in both first and second line patients, and durable response resistance ultimately develop, and optimal management is a therapeutic challenge. So post-osimertinib resistance, I am not going into the details because my previous speaker is already told that various mechanism of EGFR dependent and EGFR independent off-target and on-target mechanism of resistance. Histological transformation is there. So these are the flow chart. I am just skipping this slide. So EGFR independent mechanism is there, that is off-target resistance. So EGFR dependent mechanisms, off-target cell cycle aberrations. There are several histological transformations seen in 2 to 15% of the patients, and there are histological driven therapy is there, those who are progressed on the osimertinib. So management of osimertinib resistance in NSCLC, rebiopsy is recommended. Liquid biopsy is an inherent limitations for alternative to the tissue. Tailored approach to type is alteration is suggested. So targeted therapy for EGFR dependent alteration, we have lots of clinical trials ongoing. There are several phase 1, phase 2 and phase 3 trials that address the issue of osimertinib in the several trials. I am going into the details. So the MET amplification is one of the major therapeutic challenge those patients who are osimertinib resistance. So combination with osimertinib plus MET inhibitor is an efficacious benefit. The retrospective study as well as phase 1b study that showed that osimertinib combination with the MET inhibitors like savolitinib or durvalumab, there is some benefit. Combination of osimertinib plus savolitinib was assessed in global expansion TETON study. There are others ADCs that are coming into this picture that involved in the osimertinib progressions. So targeted therapy for EGFR dependent alteration, HER2 amplification is another subset. Those who are patient on progressed, we have Destiny Lung 01 study. Those who are Dato-DX, trastuzumab deruxtecan is used in HER2 overexpressing or HER2 mutant NSCLC. So beyond the targeted therapy, we have chemotherapy. 30 to 50% of mechanism of resistance is still remain unknown. So platinum based doublet remains the standard of care, like pemetrexed carboplatin. There are platinum based etoposide in small cell. Continuation of osimertinib is of chemotherapy is not recommended. So beyond targeted therapy, we have some data of IMpower 150 trial that showed that paclitaxel carboplatin bevacizumab plus atezolizumab has showed improvement in the PFS and OS in EGFR mutant NSCLC, those who are previous lines of TKI failure, and the PFS was sustainable better in this cohort. So now going to the clinical trials, that the amivantamab lazertinib plus chemotherapy in advanced NSCLC. These are, if we look at the Crystallis phase 1 study, the response rate is quite similar, quite impressive. Those who are patient with those MET amplified post-TKI failure. As well as the 1B of the Crystallis cohort, the overall response rate is progressively increased with addition of third generation TKI with amivantamab. So the Mariposa 2, the phase 3 randomized control trial, those who are basically del19 or L858R mutation progressed on osimertinib as the first line setting, they are randomized in the amivantamab lazertinib chemotherapy versus chemotherapy plus amivantamab plus chemotherapy arm. If we look at the overall survival and PFS, the primary endpoint of this study, the amivantamab chemotherapy versus amivantamab lazertinib plus chemotherapy, the hazard ratio of 0.48 versus 0.44, and the maximum benefit was shown that amivantamab lazertinib plus chemotherapy in these populations, and the hazard ratio, the forest plot showed that irrespective of the region, irrespective of the gender, race, body weight, performance status, all in the first line and L858R and del19 were substantially better in terms of chemo plus lazertinib plus amivantamab. So if we look at closely, L858R, the hazard ratio is more favor over this combination than the del19. So the intracranial progression-free survival is also better with the amivantamab plus chemotherapy versus amivantamab lazertinib plus chemotherapy in these combinations arm. Intracranial progression-free survival is also better with a hazard ratio of 0.36 and 0.44 in the amivantamab chemo or amivantamab plus lazertinib plus chemotherapy. So the conclusion of this study was the amivantamab chemotherapy and amivantamab lazertinib chemotherapy improved PFS more than 50% reduction or progression of death to chemotherapy. In addition to the chemotherapy, amivantamab plus lazertinib containing regimen that showed the consistent PFS benefit in all subgroup, significant higher overall response rate, significant longer intracranial PFS, early interim OS shows that favorable data for the trend to the amivantamab plus chemotherapy. The safety signals is almost comparable, and the given concurrently with the lazertinib plus chemo is the higher rates of hematological toxicities. So these combinations is now the first regimens to demonstrate improved PFS versus chemotherapy in EGFR mutated advanced NSCLC after progression to osimertinib. Now another was an ongoing phase 2 platform. This ORCHID study, they actually included the patient, those who are basically first line osimertinib monotherapy, those who are progressed, there was molecular drive-in approach, those who are MET amplified, the osimertinib plus savolitinib was given, those who are uncommon EGFR mutation as C7X79X, this osimertinib plus geftinib, those EGFR amplification group, osimertinib plus nesitumumab. The future arm is also recruiting this patient, the treatment arm, and the biomarker driven approach. Those who are basically non-matched arm for the patient with resistance to the mechanism of osimertinib are unavailable. The durvalumab plus pemetrexed carboplatin, osimertinib plus nesitumumab, these are ongoing. So the result of this study is coming, and it is in future and will tell us that which subgroup is benefited in the best of these. Another is Destiny Lung 01. The 3% of the NSCLC cohort have HER2 amplifications or mutations. So trastuzumab deruxtecan has ADC that is used in the HER2 positive population with the breast cancer and the other cancer also. If we look at the lung Destiny 01 study, the PFS benefit was shown with the median PFS of 8.2 months with the HER2 mutated NSCLC cohort in the Destiny Lung 01. Again, the Destiny Lung 01 study that showed that all across subgroup there is benefit of stable CNS metastasis and the overall response rate. So it is also a future group that established the role of HER2 directed therapy in the osimertinib. Now the osimertinib plus savolitinib combination is another combination. We have Savannah's results that savolitinib plus osimertinib plus savolitinib monotherapy in those cohort who were previously progressed on the osimertinib and overexpressed the MET amplification or overexpression. So this study has showed the outcome that overall response rate, median duration of response and PFS is better in the savolitinib plus osimertinib combinations, and the safety signals are consistent with all the subgroups. So we have the Saffron study, the savolitinib plus osimertinib in EGFR mutated advanced NSCLC, those who are MET amplified or MET overexpression post osimertinib, the savolitinib plus osimertinib versus pemetrexed plus in combination, those who are progressed on osimertinib, the PFS rate is better. The conclusion is post progression biopsy important to identify new biomarkers and determine if disease has undergone small cell or squam transformations. Optimal biomarker for MET amplification and MET overexpression are still under investigation. Osimertinib plus savolitinib associated with higher response rate and tolerable safety profile in phase 2 Savannah, as well as the MET amplification in the after progression osimertinib. So the under investigation phase 3 Saffron trial. So we have the Crystallis study, the amivantamab plus lazertinib, osimertinib relapsed cohort in the phase 1 and phase 2. I am not going into the details. The conclusion of this Crystallis is 1A and 1B, that prospective evaluations of biomarkers of response to amivantamab plus lazertinib by NGS or IHC in tumor biopsy for patient with post-osimertinib EGFR mutant NSCLC. So the Crystallis 2 cohort also the same. So the key takeaway, osimertinib is the current standard of care for patient with newly diagnosed advanced EGFR mutated NSCLC. So even there is an room for improvement. Median OS is 38.6 months and an average nutshell across the all subgroup of the trials. Numerous clinical trials are improving upon the benefit observed with the osimertinib are ongoing, including those as novel combination regimens. Biopsy after progression of osimertinib is important to determine the resistance. These are the current ASCO guideline that showed that we have to identify the on-target mechanism, bypass mechanism, or histological transformation. We have the fourth generation EGFR TKI like lazertinib plus combination with the first generation. We have pemetrexed carboplatin. We have amivantamab chemotherapy plus lazertinib. We have ADC antibody drug conjugate. We have antibody drug conjugate plus osimertinib, and the inclusion of the clinical trials. So these are the current flowchart and how to approach patient those who are progressed on the osimertinib. Thank you.